Hello and welcome. I'm your host, Catherine Banwell. Thanks for joining us for another webinar in the Patient Empowerment Network's Elevate series. The goal of these programs is to help AML patients and care partners feel educated and informed when making decisions with their healthcare team. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, let's meet our guest today. Joining us is Dr. Daniel Pollyea. Welcome. Thank you so much for being with us. Would you introduce yourself?
Yes, thanks so much for having me. I'm Dan Pollyea, and I work at the University of Colorado, where I lead the leukemia team.
Thank you so much for joining us today. As part of this new series, we're learning more about researchers like you. You're on the front lines of advancing AML care. What led you here, and why is it important to you?
Yeah, I think my path, as is everyone's, is a distinct and a bit different. In short, I think working in AML is one of the most exciting areas in medicine that a person can be in right now. It's this incredible intersection between delivering, potentially curative care, treatments to patients, and sort of harnessing the most unbelievable research-driven drug development, new therapies to patients. So it's just a really, really exciting time for all of us who work in the AML field because of all that those opportunities bring to bear.
Yeah. Let's start by having you define AML for the audience.
Yeah, AML, acute myeloid leukemia, it's a type of a cancer. You can think of it as a cancer of the bone marrow, and it's the likely result of several abnormalities, or sometimes I call them mistakes, that can occur in stem cells or a stem cell in the bone marrow. And those mistakes that occur, most times we don't understand why they happen. And we don't, in most cases, they're completely out of a person's control. This isn't something that comes on because it runs in a family in most cases, or because of something somebody did or didn't do. These appear to be pretty random events that occur, but these mutations that occur in these sort of stem cells in the bone marrow cause a cell to become a cancer cell. And over the course of a variable amount of time, these can evolve and develop into this condition, AML.
Okay, thank you for that. Health literacy, which is defined by the ability to find, understand, and use information for health-related decisions, is essential. Would you expand on the term health literacy and why it's important to accessing quality AML care?
Yeah, so I think health literacy in our field is a challenge, because these are acute conditions that come on oftentimes very quickly. And, these are not diseases that are top of mind. Most people don't know somebody who's had this. They're not common. Only about 30,000 people every year in the United States will have AML. So it's very hard to have any sort of background in this. And for most patients, because of the pace at which this disease occurs, it can be very difficult to sort of read up on it before meeting with a provider or an expert or a specialist. So there's a lot of challenges or barriers to health literacy. But, like anything, the more a person knows, the more sort of empowered they can be, the more ability they have to ask questions, and seek care at sort of the optimal place. What I find often is that health literacy is best harnessed by a patient's a team. So in other words, their support system, their family or friends, because it's so much to deal with in such a rapid succession. to get this diagnosis and to usually be feeling very poorly, to also be expected to sort of have read the most relevant literature and come armed with that information is often too much at the beginning. So in the beginning, I think it's best, to leave that to your support system. And then as time goes on and as you start treatment, get comfortable, health literacy in our field, it becomes a more prevalent issue. And I think that when patients learn the most about what is how the field has evolved and where we are, the better that they can potentially do.
Well, that leads us perfectly into my next question. What resources do you suggest for boosting knowledge about AML?
Yeah. AML is like so many fields in medicine, but probably more so, moving so quickly that sort of the usual Google search is not going to, in most cases, bring up the most important, the most relevant information. So, I think that there are some organizations out there that do a really good job of educating patients. The Leukemia and Lymphoma Society is one. They have a good website. They have people you can contact, and they have really good information that's available to patients and their families. So, that's where I typically recommend people start. And then from there, based on their interest in, education level and things like that, there can be other resources. But I think the Leukemia and Lymphoma Society is a great place to start.
Yeah, okay. Newly diagnosed patients and their care partners are often overwhelmed, as you mentioned earlier. What advice do you give them at their first appointment?
Right. So, this is a huge challenge. Anybody in this situation would be feeling like this. So first of all, it's sort of like, it's okay to feel like this. It's normal. It would be unnatural to not be overwhelmed with what you're going through. That's an important message. And then, I think there's this period of time between diagnosis and a plan that is particularly anxiety provoking. And so, as your doctor and their team sort of sorts through the necessary information to get a plan together, just know that that is a very anxiety provoking time when you're being told that you have a really significant and serious disease, and we don't have a plan yet. So making sure that you sort of comfort yourself during that period, knowing that that is temporary and that is potentially the worst anxiety you will feel, I think can be helpful. And then from there, once the plan is sort of in place and enacting it, it's really just focusing on like short-term goals. So, instead of thinking 3 steps ahead and, how's the transplant going to work? In the early days, focusing on, okay, how am I going to get into a remission? And how am I going to feel day to day? How can I feel as best I can day to day? What's the best path to a remission? And then, once you sort of meet the goal of remission, okay, what's next? How are we going to cure this? So, thinking through sort of in short bites, I think is best.
Mm-hmm. Are there other key questions that they should be asking their doctor or their healthcare team?
Yeah, I mean, at diagnosis, depending on the situation, this is a disease that can be cured. And so, from the first day, asking, is that a possibility for me? Is there a curative plan for me? And what might that look like? I think is an important question to ask from the beginning. Making sure you communicate your goals and your wishes, how you define quality of life, what that means to you. And in that way, that can really help inform your doctor and their team to put together a plan that sort of is most customized to you.
Yeah, that makes sense. When it comes to choosing AML therapy, it's important to work with your healthcare team to identify what will be best for you. Would you walk us through the factors that are considered when choosing therapy for AML?
Sure. Yeah. So, we now have options with treatments for this disease, and For decades, that wasn't the case. This was a one size fits all type of a disease. And in the last 8 years, that has completely changed. So there are approaches at diagnosis that vary between very intensive chemotherapy and less intensive treatments. What we call targeted therapies in some cases can be considered or be appropriate. And so, having a sense after learning a little bit about this of how, how much would you be willing to tolerate an intensive chemotherapy regimen and all the risks inherent in that, if that's even being presented as an option? And if so, what does that look like? And if not, hey, what are the other options? If that sort of doesn't sound like something that you would be willing to accept. So, I think those kind of probing questions, first asking yourself and then sort of translating that into your treatment team into, hey, this is sort of how I define quality of life, and these are some red lines that I wouldn't cross. That can really help the healthcare team, because again, this is not one size fits all anymore. We do have several options to consider at the time of diagnosis.
Mm-hmm. Well, what other factors would you take into consideration? Do you look at age and overall health and fitness, test results?
Absolutely. So the relevant factors at the time of diagnosis would be, as you described, age to some extent. And there's no magic cutoff. When a person is a certain age, this is no longer a treatment option, but age just gives us guidelines. Other comorbidities, other, diseases that you may be dealing with, things in your past, organ dysfunction, all of those things are really highly considered. And also sort of your own attitude toward, hey, how would I be okay with a month-long stay in the hospital? Or is that something that, there's no sort of outcome that would be okay for me to withstand. But then the other huge part of this are things that are sort of at diagnosis unknown to you and unknown to your doctor for a little bit. And those are disease factors. So what are the mutations that make up your disease? What's making your disease tick? And now, just with normal clinical care, we have unbelievable access to this information. I mean, we can essentially learn within a week or two, every relevant mutation that's contributing to your disease. And that helps us tremendously with respect to prognostication, sure, but also treatment selection, because there are some treatments that, will work, we think, better with certain disease biology, and other treatments that will work less well. And we even have targeted therapies. So based on particular mutations or other abnormalities, sort of a rationally designed therapy for exactly that disease biology. So that is also, a huge part of treatment selection, and we call those disease factors.
Mm-hmm. Why is molecular testing important following an AML diagnosis?
Right. So this is basically gets into what we were just discussing. So that molecular testing is the testing that will tell us all the mutations that make up your disease biology. And so, that is crucial for prognostication, but also treatment selection. So molecular testing is really, and frankly, also, when thinking about how to potentially cure your disease, those will be factors taken into account to make decisions that are pretty significant, such as, should you receive a bone marrow transplant at some point in the future or not? And the reason it's so crucial to get this done at diagnosis is, after diagnosis, we start a treatment, and hopefully we put your disease into a remission. And at that point, we no longer have access to your disease cells. They're gone, or they're too low to even measure. And so we need to get this information at diagnosis so that we can have it later on, so that we can really understand your disease and make the best treatment plan for you.
Right. We've covered this in past programs, but I think it's worth reiterating. Would you define induction and consolidation therapy for the audience?
Yeah, so traditionally, when we only had intensive chemotherapy treatments, induction meant let's get your disease under control. That's the first sort of line of treatment. Let's induce a remission. That's where that comes from. And then consolidation meant let's do more stuff, more chemotherapy to consolidate that remission, or you can think of it as maintain that remission, deepen that remission. All of those are sort of the same adjectives there. So induction was step one, consolidation was step two. We've retained a lot of this language into a time when we don't only have intensive chemotherapy. So we'll still use the word induction sometimes to mean let's get your disease under control, even if it's not with intensive chemotherapy. So admittedly, that can be very confusing. But if someone uses it in that manner, that what they're talking about is let's get your disease under control. And consolidation is still meant let's deepen your remission or let's prolong your remission. So those are the general terms. They're very much linked to intensive chemotherapy, which we still use, but it's not all we use anymore. So, I think it has gotten confusing, and it's perfectly reasonable to be confused about that terminology.
Mm-hmm. Would you share an overview of the types of therapy for AML, and how do you decide which patient gets what?
Yeah. So at diagnosis, because the things are very different at relapse too, but at diagnosis, the options still are intensive chemotherapy, which is a regimen that hasn't changed much in several decades, really 50 years. And then there are other treatments. There's a treatment called venetoclax that we give with that we pair with a low intensity chemotherapy treatment, either azacitidine, decitabine, or something called low-dose cytarabine. Those are the three sort of partners for venetoclax. And then there's a targeted therapy against leukemia cells that have an IDH1 mutation. That's called ivosidenib that we also give with low-dose chemotherapy. So in most cases, those are the sort of like the three general options. That last treatment with that's targeted against IDH1, we typically preserve that for older patients or those that really are not good candidates for intensive chemotherapy, but who have that IDH1 mutation, which is only somewhere around 10% of AML patients. And then then the main decision then is, do we give intensive chemotherapy or do we give the venetoclax regimen? And our policy is sort of, if we think we can cure you with intensive chemotherapy, and there's certain disease biology subtypes that can be cured potentially with intensive chemotherapy, then that would be our first choice for you. If we don't think we can cure you with intensive chemotherapy, if you don't have that disease biology, or if you do, but you're just not a candidate for that type of an approach, that's when we give the venetoclax regimen.
Are there other targeted therapies that you use?
Yes. So venetoclax is a targeted therapy against BCL2. Now, that is not one, like, unlike some of these other gene mutations, you don't have to have something. There's no mutation in BCL2 that you need to be a candidate for venetoclax. We give venetoclax pretty much to any potential AML patient. But these genomically targeted therapies that you mentioned, FLT3, before I mentioned IDH1, there's also one for IDH2. We hope there's a couple more of these coming, where these are approved for the most part at the moment are in the relapse setting. So a patient who receives a treatment and then, either doesn't respond or responds and then relapses, that's typically where we bring in these genomically targeted therapies. There's an exception for IDH1 that, like I said, that can be used now in the upfront treatment setting. But for the most part, these genomically targeted therapies are relevant in relapse disease.
When would you use stem cell transplant?
Yeah, so stem cell transplant for the majority of AML patients is still the only potential way to cure this disease. And so a stem cell transplant is something that we give for that purpose. It's something that we really reserve for people whose disease is in a remission. So nobody comes in at diagnosis and goes right into a stem cell transplant. That wouldn't work. So you first have to achieve a remission with any number of one of the combinations of things that we've already discussed. But once a patient is in a remission and doesn't have a curative strategy with like intensive chemotherapy, or some other approach, and is a good candidate for a transplant, which is a whole other sort of set of circumstances that has to be considered. That's patients who we offer a transplant for.
Okay. What about new and emerging treatments? What's out there?
Yes, so much that's really exciting here. So we've had several new approvals. We have a new FLT3 inhibitor that we can use for newly diagnosed patients who have a FLT3 mutation and who are getting intensive chemotherapy. We have even now a new therapy that's given as a maintenance treatment. It's called oral azacitidine or Onureg, which is really exciting as well. But I think the next sort of big thing in the field is going to be a targeted therapy for another subset of patients who are defined by the presence of a gene mutation, NPM1, but also by a chromosomal abnormality, something we call KMT2A. But these patients have disease that's potentially amenable to what we call a menin inhibitor. And there are several companies with menin inhibitors. These therapies are getting pretty far along. We expect approval, potentially soon for at least one of them. And then I think these are going to have a big impact on the field for those patients who have that type of disease.
Oh, that's exciting news. Where do clinical trials fit in?
So clinical trials are crucial for everything that we're trying to do. We don't make any progress without clinical trials. So that's the field as a whole. We don't move forward. We don't get any of these new treatments without clinical trials. On an individual patient level, clinical trials are also really important because for many patients, we are still not doing as well as we want to be doing with this disease. We've made progress, but there's still a lot of room for improvement. And so for an individual patient, getting access to another therapy that, although we admit we don't quite know yet whether it may be helpful, but might be helpful, I think is a really compelling situation to potentially consider participating because it is a guarantee you will help the field, and it's a guarantee you'll help every patient that comes after you through participation in a clinical trial. But all these clinical trials are also designed to help you in a situation where, we as a field don't feel like we're doing well enough. So the clinical trials totally crucial if we're going to continue making progress. And clinical trials are the reason why these last 10 years we have had such just dramatic improvement and availability of all these new therapies because literally thousands of patients have chosen to participate.
Yeah. How can patients find clinical trials that might be right for them?
Yeah, so back to the Leukemia and Lymphoma Society, they can be really helpful in guiding this, asking your doctor, hey, are there any clinical trials here or at any other center that I should be considering? And then, people who are interested in just going to the source, every clinical trial that is available is registered at clinicaltrials.org. Clinicaltrials.gov. And so going to clinicaltrials.gov and then putting in some keywords like acute myeloid leukemia, you'll see every clinical trial that's available.
Oh, that's excellent. I'd also like to add for our viewers that if you're interested in learning more about AML care and treatment, Penn has a number of resources available to you. You can find these at powerfulpatients.org/AML or by scanning the QR code on your screen. So, Dr. Pollyea, when choosing a therapy, what questions should patients be asking their healthcare team about a treatment plan?
Yeah, so at the time of diagnosis, I think it's a reasonable question to say, is my disease amenable to a cure? Can I be potentially cured? And is this treatment part of a plan for a cure? If if that is possible, then I would want to be walked through the steps to which, that's going to be executed. And if it's not possible for me to be cured, then I would like to discuss, what is the treatment plan that could potentially give me the longest duration of a remission and the best quality of life. And so, that's the conversation that I think is important to have. And then everything that we discussed comes into play there. An individual's sort of appropriateness for intensive chemotherapy versus less intensive regimens, and also the disease biology and what that may be make them a candidate for.
Yeah. Are there certain symptoms or side effects that patients should share with their care team?
Yes. So, I mean, we have a very, very sort of liberal request that, really anything should be shared. We have a 24/7 number to call with one of us on call at all times. So it's very difficult for a patient to kind of be able to appreciate, when they're going through such dramatic changes, hey, is this expected or not? So, we really emphasize oversharing concerns about symptoms. All these drugs have very different side effect profiles, and some of them are common and some of them are less common. The disease itself can cause symptoms and clinical issues. So instead of really trying to educate yourself in an impossible way on what could be or couldn't is not, related, it's better just to ask.
Yeah, get that answer. What is the role of a care partner when someone is in active treatment?
Having a care partner is crucial. This is physically and mentally extraordinarily stressful on the body and the mind. Having that support person for those purposes is really important. Having that person be an advocate for a patient, to ask those questions that may not be getting asked, to reframe questions to get the best answers, is really, really important. And then there's the more mundane things, just getting patients to their appointments and kind of keeping their morale up and those things. So, there's data and research on this that, patients with caregivers, they have better outcomes. When it comes to a transplant, a caregiver is not an option. You must have a caregiver. And the importance of that will be sort of relayed to you in the context of a discussion about a transplant. But a caregiver in the setting of a transplant is so important that it is a requirement to even be considered for that.
Yeah, it sounds like that's vital. I'd like to get to a few audience questions that we received before the program. Chris sent in this question. I would like to hear more about mutations found during molecular testing. Are there new AML drugs in trials for other less common mutations?
Great question. So at the moment, what we have clinically available are targeted therapies for patients with FLT3 mutations, IDH1 and IDH2 mutations. And there are about 50 different genes that can be mutated in AML. And so, that's a small slice of the pie. Those are relatively common mutations, but still small slice of the pie. A lot of the very uncommon or less common gene mutations, we don't have great paths to targeted therapies for them. And is that just we never will? I don't think necessarily, but I think those can be really challenging. Not every mutation is amenable to a targeted therapy, at least as far as we know now. The one that's coming that we're hopeful about is NPM1, which may be able to be targeted with one of those menin inhibitors that we talked about. So that's the next big one up. And that will probably constitute 40% of patients that have one of those mutations that I listed. But research is ongoing to kind of try to dig into this more. What I will say is that, the AML research community is so fantastic that every lead is being pursued, and there is a lab somewhere in the world whose focus is on whatever small, even the most least common AML mutation. That's somebody's focus. And so, if there were to be promising therapies developed for even rare mutations, I assure you the field would take those forward and figure out a way to do those clinical trials and, and to get to approval if it's appropriate. So, but I think that's where the landscape is right now.
Mm-hmm. This question comes from Rita. Outside of changes in blood work, what are signs that AML is returning?
Great question. So this can be a really tough one, and blood work is what we sort of hang our hat on. There are some times that patients sort of have clinical symptoms that precede changes in blood work. I will say I find that to be pretty uncommon. But some of the things that might happen that are pretty rare but might happen would be leukemic involvement of the skin. So it would appear as a rash. Some people might have some fatigue that comes on before the blood counts really change. That's also pretty rare. And then, if this disease were to work its way into any other organ or tissue in the body, it's possible, and that's rare, but it's possible that that could present with clinical signs and symptoms before a blood count change. But for the most part, the blood counts are really early sign that something is changing, and typically we'll see that before any clinical signs.
Thank you for that, Dr. Pollyea. And those were great questions. Please continue to send them to question@powerfulpatients.org, and we'll work to get them answered on future programs. So as we close out the program, Dr. Pollyea, what would you like to leave the audience with? Why are you hopeful about the future of AML care and treatment?
Well, we've made unbelievable progress in just the last 10 years. And so, just looking into the future, I see nothing stopping that progress. So it's really exciting to think about where we'll be 2, 5, 10 years from now. We never could have envisioned 10 years ago where we are now in terms of the therapies we have, how active and effective they are, and the impact that it's had on patients. So, this, again, just so proud to be part of this community, both on the patient care side and on the research side. It's such a committed group of people working around the clock on this disease to figure it out and to make some improvements. So, all those reasons, I'm just super hopeful that we'll just keep making progress, and I see no signs of anything slowing down.
Yeah. That's a promising outlook to leave our audience with. Dr. Pollyea, thank you so much for joining us today.
Thanks so much for having me.
And thank you to all of our collaborators. To learn more about AML and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for being with us today.